name is Tanner Boomersbach, and I'm a fourth-year medical student here at Mayo Clinic School of Medicine in Rochester, Minnesota.
And I'm Dr. Michael Bostwick. I'm a professor of psychiatry here at Mayo Clinic.
We're here today to discuss our article, which is titled "Weren't Asked, Didn't Tell: The Prevalence of the Communication of Suicidal Ideation in Suicide Decedents During the Last Year of Life." And this article will appear in the June 2018 version of Mayo Clinic Proceedings. Our paper was a case control study that examined a cohort of individuals who died by suicide between the years 2000 and 2009 in Olmsted County, Minnesota. And this cohort was compared to a control population of age and sex matched controls at a 2 to 3 to 1 match. The primary objectives of this study was to determine how often individuals who go on to die by suicide were screened for suicide in the year before their death, and then also how often these individuals endorsed suicidality in the year before their death. And to accomplish these objectives, we reviewed the electronic medical records of these individuals and the controls during the last year of life. We were looking for both provider chart notes and then also PHQ-9 screening questionnaires, which is a common screening tool used primarily in the primary care setting to look at depression and suicidality. In a previous case control study also examining this cohort of suicide decedents, which was also published in Mayo Clinic Proceedings, we found that individuals who go on to die by suicide actually were no more likely to have had exposure to the healthcare system compared to the control population in the year before their death. And these findings challenged an often cited notion in the literature that individuals who go on to die by suicide or that are at high risk for suicide can somehow be differentiated from control group based on their increased and greater use of healthcare in the year before they died. And so the primary objective of our study then was to build off of that current study by looking at what is actually happening at these medical appointments in the time before death in terms of how often people are being screened for suicide and how often they are endorsing suicidality. And what we found was that individuals who go on to die by suicide were not screened at very high rates for suicide, and likewise when they were screened, they did not endorse suicidality at very high rates. We actually found that less than 50% of all individuals going on to die by suicide were screened for suicide at any point in the year before death. But we also found that less than 60% of individuals who went on to die by suicide, when they were screened for suicide, actually endorsed suicidality. So this means that 40% of individuals who went on to die by suicide denied suicidality when they were screened in the year before their death. And interestingly enough, no suicide decedent ever expressed or endorsed suicidality at their final medical appointment before death. And so I think the title of our paper, "Weren't Asked, Didn't Tell," is very descriptive and kind of helps to describe the results of our paper.
Yes, and I would add, I think the results are actually pretty disturbing. The implication of some of our suicide prevention programs are that the patient will go to the doctor, that the doctor will ask the patient about suicide, that the patient will give an answer that is their honest expression of their suicidality, and that action will be taken to prevent suicide from occurring. One of the findings that I think is to underscore what my colleague said is this notion that none of the patients, 17 of them at their last appointment before death, actually said they were suicidal. This speaks to, I think, an increasing understanding that for many patients, killing themselves is an impulsive act, not one that is planned and that can be discussed conveniently with your doctor at your last appointment. There were other findings that are interesting in that a patient who did kill themselves was more likely to be asked than a control about whether they were in fact suicidal. In terms of screening, less than 10% of the controls were screened at all in the year before, in the comparable year. It's hard to know exactly what to make ultimately of these findings, except that they really do challenge many of the assumptions we're making about suicide prevention. And we hope will add to the discussion about what we can do, what we can expect ourselves to do, and what we actually cannot do to prevent suicide in the physician's office.
I think when we're talking to providers, it's important to also underscore just any patient who is expressing any form of suicidality warrants a greater risk assessment and greater conversation, greater screening. But the findings, and like Dr. Boswick said, are particularly disturbing, that even 100% compliance by providers in screening all patients for suicide would likely not prevent all of these suicides from happening, and may not even prevent the majority of the suicides from occurring.
And I think perhaps in closing, one thing that I hope this paper will do, it really is an epidemiological paper, and it provides data from a population of people who did in fact die. And the disconnect is with clinical practice, which is by definition one patient, one doctor at any given moment in time. So we hope, we don't want to be negative about the prospects of preventing suicide, but we do believe that there are lessons to be learned from epidemiologic studies such as this, and we hope that it will inform the discourse in a way that is ultimately useful and life-saving.
Thank you for listening, and we hope you enjoy our paper.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.